Marik. Today we're going to be talking about COVID-19. Obviously this is a really important subject, so I have a lot to cover. I'm going to try and finish this in an hour, and if we could leave all the questions until the end. So in terms of my disclosures, just to let you know, I don't own any drug companies, I don't own shares in any drug companies, and I already have no conflict to disclose. So this is a very complicated topic. It's complicated because the science is very complicated, as you'll see. And then, as almost everybody knows, just to add to the complexity, we have the involvement of politics, pharmaceutical industry, money, and people's beliefs which have nothing to do with science. So the summary of my talk, I'm going to review the virology of SARS-CoV-2. I'm going to review the stages of COVID-19 disease. This is absolutely essential to be able to treat this disease. I'm going to highlight the immune dysfunction and thrombophilia as major pathogenic mechanisms in COVID-19 disease. And then I'm going to discuss the approach to therapy in each stage. So just to begin with, it's really important to know this is not the flu. This is not the flu by any means. So you can look at the mortality rates of flu and COVID in the US, and you can see for every single age group, the mortality from COVID is exceedingly high. And as we'll see, the disease does not look like flu in any respect. So where did this virus come from? So both SARS, MERS, and CoV-2 appear to have originated from bats. SARS went through civet cats to humans. MERS was transmitted through camels to humans. The intermediate host in COVID-19 or SARS-CoV-2 has really not been determined. So it's important to review the characteristics of this virus. It's called a coronavirus because of these crowns on the surface, and these are due to the spike glycoprotein. In addition, there's an E protein, a membrane protein, a viral envelope, a nuclear capsid protein, and the RNA genome. It's an enveloped virus about 1.1 micron in diameter. So how does the virus get into the cell? Well, we know that it binds angiotensin converting enzyme 2, which is a transmembrane protein present in the upper airway and on the type 2 pneumocyte. So the spike protein binds to ACE2. It then requires a number of other processes to process this, the most important being the transmembrane proteolytic cleavage enzyme 2, which cleaves ACE2. In addition, furin and heparan sulfate are required. As a result of this, you get fusion of the viral membrane with the infected host cell, and you get penetration of the payload, which is the viral RNA. So the RNA of CoV-2 has been well characterized. It's about 30,000 kilobases, and it's of some importance. So this beginning part is called the non-structural protein, or open reading frame 1. This part here has the structural proteins as well as some accessory proteins. So what happens, this protein here gets translated into a polyprotein, which then you can see it here, and then the proteases break it up into 16 proteins. These are called non-structural proteins. So this genome codes for 16 non-structural proteins, 4 structural proteins, and 8 accessory proteins. And you'll see all of these proteins play a pivotal role in the pathogenicity of this extremely devious virus. So this again is the genome. We have open reading frame 1A and 1B, which codes for the polyprotein. And then the spike, the membrane, and the end protein here. Now, what we need to remember is that human ribosomes can only read one piece of RNA and code for one protein at a time. So the way the virus achieves this is due to non-synchronous reading. It creates these subgenomic RNAs. So these are pieces of RNA that code for various proteins. As you'll see, these are known as subgenomic RNAs. It's probably important to review the PCR because I don't think people recognize this. So when you do a PCR, you are not detecting the entire genome, and you're in fact not detecting live virus. So different PCR tests target different parts of the viral genome. So the CDC test targets this N protein, which you can see is about 100 kilobases. So it's out of the 30,000 kilobases, it's targeting a very small part of the viral genome. Many of the European and Chinese studies target the open reading frame 1A or 1B, and many target the RNA-dependent RNA polymerase. And you'll see this becomes important. So the PCR test does not test the entire viral genome, and it doesn't test for live virus. It detects for fragments of the viral genome. So there are all of these non-structural proteins, and each of them serves very critical functions. This is an exquisitely designed virus. And in my opinion, I don't think humans have the intelligence to have designed such a virus. So the first one is non-structural protein 1. So as you can see, what this protein does is it intercalates in the cleft of the human ribosome. And what it does is it prevents the human ribosome from reading human RNA. So it essentially switches off protein synthesis in the cell. But it's a devious protein because it allows the ribosome to read viral RNA. So it switches the host cell from producing human protein to basically a viral protein factory. The other non-structural protein are two proteases which basically break down the polyprotein, a RNA-dependent RNA polymerase, which is involved in viral replication. Many of these NSPs block interferon, both synthesis and its mechanism of action. They block natural killer cells. So interferon and natural killer cells are the prime host viral defense mechanisms. And you can see the virus knocks them out. It disrupts autophagy, it blocks apoptosis. One of them caps this subgenomic RNA, allowing it to be read. It's a truly astonishing virus in that it proofreads its genomic RNA to see there are no mistakes. And if there are mistakes, it cuts them out with an endonuclease. And you'll see there's a thing called a double membrane vesicle. It puts pores in them. So these proteins perform really important function. So this is the life cycle of the virus, which is somewhat important to understand if we're going to treat this disease and use targeted therapy and understand it. So as we see here, we have genomic RNA. The genomic RNA gets translated. It can only make one protein. It makes the polyprotein, which then gets broken down into these non-structural proteins. What then happens is some of these non-structural proteins form what's called the replication transcription complex. So this is a double membrane vesicle. And basically what these vesicles are little factories that allow uninhibited replication of viral genome. Normally what would happen in these double membrane vesicles is through the process of autophagy, lysosomes would fuse and destroy the contents. However, these non-structural proteins are really clever and they switch off autophagy. So basically it allows the virus to replicate undisturbed in these vesicles. What then happens is there are pores in these vesicles due to, again, non-structural protein, which allow the genomic RNA to come out, converted into plus genomic RNA, and then combines with the nuclear protein and gets put into these Golgi intermediate compartments. We can see what happens to the subgenomic RNAs. The subgenomic RNAs get moved through the pores to the endoplasmic reticulum, and through ribosomes on the endoplasmic reticulum, they translate the M, E, and S protein, which then gets incorporated into the membrane of the Golgi apparatus, which then forms this complex, the ERGIC, forming a vesicle, and the virus is released. So what happens is the cell becomes a factory, and as we'll see, it's a highly efficient factory. It doesn't destroy the cell because that would not be in the virus's best interest. So it hijacks the cell and turns the cell into a factory that makes virus. So these are the replication transcription complexes in the cell. These are complicated structures. They have pores which allow the genomic and subgenomic RNA to be directed out, and they're also connected to the endoplasmic reticulum. And through a process of these proteins inhibiting the autophagy mechanism, these complexes survive. So next we get onto this really important question is, how is SARS-CoV-2 transmitted? So it appears the most common is droplet spread. So droplet spread is by particles more than 5 microns and travel less than 6 feet. The other postulated mechanisms are aerosol, and these involve particles that are less than 5 meters and travel greater than 6 feet, and then formites. Now, as you know, this has become an exceedingly controversial issue, and the CDC is really not sure what its position is, and as of this week, it's changed from being airborne to not airborne to droplets, so they don't seem to understand. And this is of some importance, but you'll see actually it's not really important. So droplet spread, this is large particles go about 6 feet. Airborne transmission particles go into the air and can travel some distance. For reasons that are unclear, this has become a highly controversial issue. However, the reality is that there is probably a continuum of particle size. It's kind of absurd to assume that particles are one size only. So it appears that there's a continuum of size, and the particle size changes with time. Now, this is one of the best epidemiological studies, and this study supports the concept of droplet spread. So what they did, these were people who were infected on a high-speed train. The train had closed windows and recirculating air. They knew where every passenger was sitting on this train. They then did intensive contact tracing. And what they found is the risk of a contact getting infected with SARS-CoV-2 was directly related to how far apart the contact was from the index case. So if the index case sat right next to the contact, the risk of infection was exceedingly high. So you can see on this graph below that the further apart the contact was, the lower the risk of infection. So the risk of infection depended upon how far away the contact was from the index case and the contact time. So this model tends to support the concept of droplet spread. However, this very intriguing study, they took people who were infected with the virus, and what they did is they measured the amount of virus in their exhaled breath. So these people were just breathing quietly. They were not coughing, sneezing, speaking, singing, or yelling. They were just sitting and breathing. And what they found is that up to 10 to the 5 viruses per minute were exhaled in the condensate. So that's over 1 million viruses per hour in tiny little aerosols. So it seems that both mechanisms probably play a role. But actually, as you'll see, it doesn't really make a difference. Because what we know, and this is so critical, the most effective way of breaking the transmission of this disease is to wear a mask. Let me say that again, because every single person in this country should be wearing a mask. As we can see from the experience in New York City, the effect of social distancing, staying at home. The intervention that had the greatest effect was wearing a mask. And what we now know is masks not only protect other people, but by reducing the inoculum size, they actually protect the wearer. Very important. So it's important that everybody wears a mask. So this is nicely shown in this study. It's called The Tale of Two Cruises. The first was the Diamond Princess cruise, as we know, that got moored in Japan, and the passengers spent a prolonged time. Nobody wore masks on this ship. There were lots of infections. There were a whole bunch of deaths. They tested everybody. About 20% of people had asymptomatic infection. Then there was another cruise bound to the Antarctic that had infected passengers. What happened on this ship is everybody wore masks. There were no deaths, very few symptomatic infections, and surprisingly, 81% of the infections were asymptomatic, which makes the point that wearing a mask reduces inoculum size and therefore reduces the risk of developing symptomatic disease. So what about the pathophysiology? So as we said, the virus is either inhaled through aerosol or droplets. It's then deposited in the upper airway, predominantly the nasal mucosa. It then replicates in this factory. The nose and nasal pharynx gets turned into a highly efficient viral factory. And as we'll see, trillions of viruses are produced. What then happens is some people will microaspirate these virons, and this probably depends upon the viral load. So what happens is the SARS-CoV-2 infects ACE-expressing cells of the nasal epithelial tract, upper respiratory tract. We then get some microaspiration, and the virus affects ACE2 expressing cell type 2 alveolar cells, and this causes a mild pneumonitis, and in many patients is asymptomatic. And then you get severe disease, which we'll talk about, which is due to the massive inflammatory response to dead virus. So this is the alveolus. People kind of forget what a type 2 pneumocyte is. So these are these cellular cells that make surfactant and are part of the structure of the alveolus. Now, what most people aren't familiar with, and this is really important, is that people think ACE2 expression is highest in the lung. That is not true. The highest ACE2 expression is in the nasal epithelium and in the nose. So that's why the virus replicates like a mad thing in the nose, and the infectivity is highest in the nose. This is really important because ACE2 expression and infectivity is highest in the nose. You get massive replication, and then we get some degree of aspiration. So this comes to the concept of the stages of COVID. And this is such a fundamental concept that we need to spend some time reviewing. So first we have the incubation period. The mean duration of the incubation period is 5 days. Now, about 20% of infections are completely asymptomatic. So probably because of a low viral load, that the host is able to kill the virus, and there we go, we're done. However, some patients develop the symptomatic phase, in which you have ongoing viral replication. This lasts until about day 11, okay, so about 6 days. During the viral replication or symptomatic phase, patients have fever, malaise, cough, headache, diarrhea, etc. Towards the end of the symptomatic phase, you can see here, the virus is now dead. It's been killed, presumably delayed innate immunity and the effect of cytotoxic T cells and cellular immunity kick in and kills the cells by apoptosis. But what happens is, because one's had such intense viral replication, what you get left is viral debris. So this is predominantly viral RNA fragments. And then these fragments then initiate this immune dysregulation syndrome with cytokine storm, macrophage activation syndrome, T cell dysfunction. So what's important to recognize is during the early and late pulmonary phase, this is the response to dead viral fragments, and you get progressive hypoxemia. And obviously, as we'll see, this has profound implications for how you treat the patient. Just to summarize, giving antiviral therapy once the virus is dead is kind of dumb, because once something is dead, it can't be more dead than dead. So giving antivirals or convalescent serum or monoclonal antibodies at this phase is kind of dumb. Conversely, giving anti-inflammatory agents, particularly steroids, while the virus is replicating is not a good thing, because it's going to increase viral replication. So this is the stages of the syndrome with the symptoms. Now in this slide, day 1 is not day 1 of exposure, it's day 1 of symptoms. So you can see fever lasts about 12 days, and I should add the top blocks are patients who live, the bottom hatched are patients who die. So you can see fever, you can see cough. Now what is absolutely characteristic is people are symptomatic for about 6 days, then on the 7th day they develop respiratory symptoms. It's very classic, so they go through the incubation phase, the symptomatic phase, and then on day 7, at which time the virus is dead, they then start developing shortness of breath and hypoxemia. So there is this transition period. They're short of breath, usually about for 4 days, gets progressive. They go to the ICU, usually about day 11 or 12. They were there for 2 or 3 days. They get on a ventilator, and as you'll see, they all die. So this is important to recognize how these patients progress. So this is progressive lung disease due to microaspiration of viral-laden particles. That's why you see these peripheral ground glass opacities. And clearly, the more the patient aspirates and the more these infiltrates develop, you get more widespread alveolar disease. So again, this is really important. We have the incubation phase, the symptomatic phase, and the pulmonary phase. So again, in green is live virus. So virus isolation from the respiratory tract. Note when the patient is most contagious. So the patient's most contagious for about 2 days before they develop symptoms, and about 2 or 3 days after they develop symptoms. This is the time they're most contagious. But note the nasopharyngeal swab. So this is the PCR, which is not picking up live virus, but is looking at minute segments of oligonucleotides of RNA fragments. So the nasopharyngeal swab will stay longer for a much longer period of time than you have active virus. So you can see the PCR is likely positive for the first 3 weeks, then becomes negative, and then at the time the virus disappears, the host develops both IgG and IgM antibodies, obviously indicating the development of cell-mediated immunity. So this is an important slide. There are some key slides. This is a key slide because it emphasizes exactly what I've been saying. So they did viral culture from the upper respiratory tract and correlated with viral load. So these dark circles represent cases in which there was live virus. So these were replicative viruses that could replicate. And there are 2 points. Firstly, that no patient had replicative virus past day 8. So after day 8, as we've said, there's no longer replicative virus. And those patients that had replicative viruses tended to have a much higher viral load. You can see 10 to the 9 virus copies per mole, which is, a million viruses. What you should also see is that PCR was positive in this study up to 70 days. So the fact that the patient has positive PCR, all this means is the patient has fragments of non-replicative DNA. The presence of a positive PCR does not mean active virus. And I should go back and say one other thing about the PCR. So you can see the PCR is maximum at about this time here, which is day 8. But what folks don't recognize is that patients who have proven COVID-19, the swab, the nasopharyngeal PCR, is only 80% sensitive. So that means 20% of people who have COVID, which we know from the antibody response, do not have a positive PCR. So a negative PCR does not exclude COVID. And COVID is essentially a clinical diagnosis. So this is again another study which shows the same thing. This time, instead of using log of the viruses, they used the cycle threshold of the PCR, which is the inverse of the log. So the lower the cycle threshold, the higher the viral load. And again, you see exactly the same thing. So these are patients who have replicative culturable virus. You can see and these were people who had severe disease. After day 10, none of the patients had active virus, although you can see the PCR remains positive for a prolonged time. Now, this data is reinforced by this very good study in which they did contact tracing. So the question was, how many days of symptoms is the patient infectious? So what they found is patients were infectious, i.e. transmitted it to a contact 2 days before the onset of symptoms, but only up to 6 days after symptom onset. So after 6 days of symptom onset, there was not a single case of transmission. So again, this highlights the fact that by the 8th day you have no culturable virus, and presumably the load of virus at day 6 was so low that it could no longer transmit virus. So this again reinforces this concept of the duration of viral replication and the duration of infectivity. So getting to the pathophysiology. So this is an alveolus. So what happens is about day 8, day 9, you have these dead viruses within the alveolus. It releases all of the massive amount of viral RNA as well as many of these accessory and non-structural proteins. These are then taken up by phagocytic cells, mainly macrophages, and produce the cytokine storm. As we'll see, these RNA fragments are potently immunogenic, causes this profound inflammatory response. In addition, we have an endothelialitis, so we have virus infects the the endothelium, damages the endothelium. We have leaky capillaries. Most importantly, we get release of von Willebrand factor, activation of clotting, and we have this profound thrombogenic state. So we have inflammation and microvascular clotting. So this is a slide which kind of illustrates what we've been talking about, and this compares the flu or other common viruses to COVID. So what the flu does, influenza, it stimulates interferon-stimulated genes and makes interferon B, which together with natural killer cells is the prime host defense mechanism against viruses. What COVID does is switches off these genes. It completely switches off interferon. Influenza does cause some stimulation of the immune system, cytokines and chemokines. But what happens with COVID is you get this overwhelming expression of these inflammatory mediators. So you can see COVID differs significantly from these other respiratory infections. So this slide, elevated plasma levels of selected cytokines in COVID-19 reflect viral load and lung injury. So you can see this was just a sample of the cytokines. There is a wealth of cytokines that are increased. You name it, they increased. And here they're using cycle threshold. So the lower the cycle threshold, the higher the level. And you can see that the higher the viral load, the more cytokine they produce. It just so happens that interleukin-17 actually is a pivotal cytokine in perpetuating the inflammatory response in COVID-19. So you can see there's a massive production of cytokines which reflect the cycle threshold. The cycle threshold reflects the amount of RNA. It does not reflect the amount of living virus. So the host is developing a profound inflammatory response to dead virus. So we have this cytokine storm. So this is an excellent study which I think supports what I have been telling you. So this was from SARS, and the title is Extraordinary GU-rich single-stranded RNA identified from SARS coronavirus contributes to an excessive innate immune response. So what they did in this study, they took fragments of single-stranded RNA. You can see here single-strand RNA fragments, wasn't the entire genome, and they were found in vitro to have enormously powerful immunostimulating activity, inducing considerable levels of pro-inflammatory mediators. And these are mediated through your intracellular pathogen receptor recognition molecules, toll-like 7 and toll-like 8. So you have this massive amount of RNA fragments. These get phagocytosed by your macrophages, then through these toll-like receptors have a profound stimulation of the immune system. So they're profoundly immune stimulating. When they injected these fragments into mice, they had acute lung injury with high death. So they were not injecting live virus. They were just injecting little fragments of RNA, which makes the point that these RNA fragments play an important role in the cytokine storm associated with the dysregulated immune response. In addition to the cytokine storm, we have abnormalities of cell-mediated immunity, which may be partly dependent, perpetuated by the cytokines. So in this study, they measured CD3 cells, which are T cells. You can see the levels are significantly decreased. They measured CD19 cells, which are B cells. They measured natural killer cells, and these are the most important antiviral cells. They were decreased. But not only were the cells decreased, they had an abnormal phenotype. So instead of being an activating phenotype, these were an inhibiting phenotype and had decreased expression of porphyrin and granzyme A. So what happens, the natural killer cell binds to the viral infected cell through porphyrin and injects this granzyme and kills the cell. You can see natural killer cells get knocked off. In addition, you can see the abnormalities of the CD4 helper cells, decreased numbers, and decreased ability to make interferon. If you look at the CD8 cytotoxic cells, these cells have a senescent phenotype, again interfering with the ability of cytotoxicity. So you can see that this pesky virus causes havoc to both the innate and adaptive immune system. This is probably one of the best papers that have been published. So this was an autopsy series from Mount Sinai. What they did is they collected clinical, biochemical, microbiological, and pathological data and try to put this all together to create a picture of what COVID does. And it's entitled Pathophysiology of SARS-CoV-2, Targeting of Endothelial Cells Renders a Complex Disease with Thrombotic Microangiopathy and Aberrant Immune Response. Basically what they found, endothelial damage and an imbalance of both innate and adaptive immune responses with aberrant macrophage activation, which plays a central role in the pathogenesis of this disease. There was very little direct cytopathic effect. So in fact, it's not the virus killing the host, it's the host response to the dead virus, which is killing itself. The other thing to note, this is an organizing pneumonia. It has the features of an organizing pneumonia. This is not ARDS, and that has been a big mistake. Many people considered this ARDS. They treated the patients as if they had ARDS, and they did a lot of harm. This disease has the features of an organizing pneumonia, responds differently to ventilation, and responds to steroids. This is what an organizing pneumonia looks like pathologically with these fibrotic buds in the alveolus and airways. In addition, as we said, you get an endothelialitis with thrombosis and clotting. So this was a very good paper in New England Journal of Medicine showing that you get a severe endotheliitis with microvascular thrombosis. So going on to the clinical aspects of this disease. As we know, there's enormous clinical heterogeneity from asymptomatic patients to mildly symptomatic patients to patients who have severe disease and patients who die. And this depends on a whole number of risk factors. As we said before, inoculum size appears to be really important. So in this instance, size does matter. The bigger the inoculum size, the greater the viral replication, the greater the viral load, the greater the risk of aspirating, the greater the risk of having all of this viral debris. So inoculum size matters. Secondly, we have ACE2 expression of TMPRSS2, which happens to be androgen mediated, and then age, sex, obesity, race, immunotype, vitamin D, status, comorbidities, the presence of cross-reactive immunity. And many of these factors interact with each other. So as we've said before, age is a really important determinant of mortality. So this is from the early series from Wuhan. You can see the mortality increases dramatically with increasing age. And in the right side of the panel, you can see the risk of men dying is significantly greater than that of women. Now, this is a study we did contrasting the biochemical or inflammatory profile of men versus women, and what we found is males have significantly higher CRP, significantly higher ferritin, much higher D-dimer. So for a whole host of reasons related to testosterone, estrogen, and the X chromosome, the predominant reason is males have an exuberant inflammatory response. Another factor that's really important is obesity. Obesity is a massive risk factor, sorry the pun, you can see a linear increase in the risk of death with increasing weight. And this probably has a number of mechanisms, but probably the increased inflammatory response. Again, we can see increase in age and increase in males as opposed to females. This was a study we did here, basically showing that the two most important predictors were the CRP on admission and the patient's age. We need to look at biomarkers because they dichotomize patients quite nicely into survivors versus non-survivors. As we can see, this is what happens with the D-dimer, a very important predictor and likely due to clotting activation. The lymphocyte ratio, patients get lymphopenia from T-cell dysfunction. IL-6 is a marker of cytokines, and again, your serum ferritin. So there's a very close dichotomy between survivors and non-survivors based on their inflammatory biomarkers. So now we get into the important part, which is how do we treat these patients? And we need to get back to this initial slide because it's vitally important. And as you'll see, folks do not understand this. If you don't understand the disease, you can't treat the disease. So essentially, we have a viral replicative phase. So if you're going to use an antiviral agent, you want to use it when the virus is replicating. Once the virus has stopped replicating, it serves no useful purpose. Secondly, once patients have transitioned into the pulmonary phase, they have this enormous immune dysregulation with profound cytokine storm. The antiviral therapy is going to be a complete waste of time. What you need is potent anti-inflammatory therapy together with anticoagulation. So you can see why it's so important. It's absolutely critical to distinguish the different phases of the disease, and the treatment is very phase specific. So again, here we come back to the same slide. Incubation period, the symptomatic period. This is your O2 saturation. O2 saturation starts to fall here, and that's the trigger that you're entering the pulmonary phase. Note again, viral replication goes up and it comes down by the time the patient's entering the pulmonary phase, and it's the inverse of the inflammatory response. So as the viral replication is going down, the inflammatory response again is becoming intense. Again, showing the inverse relationship between viral replication and the inflammatory response. So again, antiviral therapy during the symptomatic phase, and you start anti-inflammatory therapy in the pulmonary phase and escalate. So we're going to go through some studies which make this point very clear. So this is the remdesivir study. This was the first study out of China, and with this study, as in the next study, they used the time to clinical improvement. So this was randomized, double-blind, placebo-controlled study. So you can see in terms of time to improvement, there was no difference. In terms of viral clearance, surprisingly, no difference. We then come to the Act 1 study, published in New England Journal of Medicine recently. The primary outcome was time to recovery again, and what the study showed was that the mean time to recovery decreased from 15 days to 11 days. There was no difference in mortality. So this is not a patient-centered outcome. This is a Wall Street-centered outcome. Most patients just want to be better. They don't care if it takes 2 or 3 days. But what's absolutely critical, this is data published in the New England Journal of Medicine, is to look at the groups of patients that did and did not benefit. So you can see the patients not receiving oxygen, i.e. those who did not have the pulmonary phase, was the only group of patients who showed a clinical response in time to resolution. Patients receiving high-flow oxygen or non-invasive ventilation, not even on a ventilator, showed absolutely no response to remdesivir, which absolutely makes sense from what we've said. Once the patients have transitioned to this phase, they do not have viral replication and will not benefit from an antiviral. The number of patients in this country that receive remdesivir at this phase is truly astonishing, and people, rather than doing something useful, are waiting for this ineffective drug to become effective. So I think Gilead has perpetuated this awful myth. And another thing to be wary of is what they did, which was very naughty. They were very naughty boys and girls. What they did is they changed the primary endpoint towards the end of the study to make the study positive. That's usually regarded scientifically as a big no-no. This is the follow-up remdesivir study in less sick patients, in which they were randomized to 5 or 10 days of treatment and essentially basically made almost no difference. So that's antiviral therapy. We now have to move on to the pulmonary phase and weathering the cytokine storm. So we're going to talk about the math protocol for the treatment of SARS-CoV infection, the scientific rationale. As I've explained, the 3 core pathologic processes leading to multi-organ failure and death. Number 1, hyperinflammation, the cytokine storm. This is critical. Secondly, hypercoagulation. Patients develop increased ability to clot, both microthrombosis and macrothrombosis. It underlies the disease pathophysiology. And because of the above, these people develop severe hypoxemia, likely due to blood flow VQ mismatching. So, how do we treat them? We use the math protocol. The math is quite simple. 1 + 1 = 2. So this is the math plus hospital treatment protocol for COVID-19, which includes intravenous methylprednisolone, ascorbic acid, thiamine, low molecular weight heparin, and just for the full Monty, we add statin, zinc, vitamin D, famotidine, magnesium, and melatonin. So why corticosteroids? Because corticosteroids are the most potent inflammatory drugs that we currently have. Corticosteroids target multiple pathways and events in the inflammatory cascade. They are potent anti-inflammatory agents. So this is a very important study. There are a few key studies. This is important. And the title, COVID-19, Disease Pathways and Gene Expression Changes Predict Methylprednisolone Can Improve Outcome in Severe Cases. So what they did in this futuristic study is they took cells, infected them with SARS-CoV-2. They then looked at which genes were upregulated and which genes were downregulated. Then using complex mathematical models and known high potency computations, they looked at thousands of drugs which would specifically target those genes which were up and down regulated to restore homeostasis. And as you can see, the drug which hit the highest hit in this study published in Nature Review was methylprednisolone, followed by gold. Nobody's going to give IV gold, and then prednisolone. Interesting, dexamethasone and hydrocortisone were much lower on the list. So we then come to the recovery study, in which they randomized a good number of patients. This was not a small randomized study, to dexamethasone 6 milligrams a day or placebo. You can see the significant reduction in mortality, 35% patients on mechanical ventilation, and again, patients just on oxygen, a 20% mortality reduction. So again, patients in the pulmonary phase of COVID-19 who received corticosteroids, there was a significant reduction in mortality. And this becomes important because this is the only intervention that has been proven to reduce the mortality of COVID-19. And it's important to repeat that. This is the only intervention which has been proven to reduce the mortality in patients with COVID-19. And I think that the amount of public awareness and general information on this drug was dwarfed by remdesivir, which, as we can see, was a particularly useless drug. What's important in this study is what happened in the patients who were in the symptomatic phase or not in oxygen. There was a trend towards harm. So again, this study is the opposite of the remdesivir study because it's acting differently. The patients that benefited were those receiving mechanical ventilation and those on oxygen because they had pulmonary involvement. Those with no pulmonary involvement tended to do worse, presumably increases viral replication because this is the viral replicative phase. This becomes also important in that although the recovery study was an absolute game changer, it was an absolute game changer. Unfortunately, they used the wrong steroid in the wrong dose. So this is a table of all the studies which have looked, except for one we'll talk about, of corticosteroids in COVID. You can see this is methylprednisolone, and here's the number needed to treat, exceedingly low. This is dexamethasone, and this is hydrocortisone. Clearly demonstrates that methylprednisolone is the most effective drug in reducing mortality. And you can see remarkably in these two studies from Italy, these were sick ICU patients, a mortality of 7% and 5.9%. Now, what's important is not only the timing, but the duration. So you want to start early, but you want to treat. This is a vicious disease. You've got to treat them for at least 7 to 10 days. You've got to follow the CRP. So this was a patient in the GICU. Unfortunately, for a administrative mix-up, the treatment was stopped at day 4. You can see what happened, a rapid escalation of CRP. We then restarted steroids and it came down again. This is a randomized study in clinical infectious diseases. With steroids, they made a big deal about it, but you can see why this is a flawed study. So patients were randomized on day 13 of symptoms. That means they had about 7 days of respiratory symptoms and were on a ventilator for 3 days. Why in heaven's name would you wait 3 days a patient on a ventilator before treating them with steroids? And then what did they do? They stopped treatment on the 5th day. So if you design a bad study that's destined to fail, it will fail. We're briefly going to talk about ascorbic acid. So all species on this planet except humans and guinea pigs make vitamin C. It's an important hormone and stress hormone. A goat makes about 2 to 4 grams a day. When this little goat gets stressed, it doubles its vitamin C production. Humans have a fatal mutation in the last step, the gulo step, cannot make vitamin C. So anthropoid primates and guinea pigs have this fatal mutation and they cannot make vitamin C. Vitamin C has a whole host of important anti-inflammatory properties. It also is specifically a good antiviral agent primarily by acting on interferon. This is one of the studies looking at vitamin C in COVID. You can see mortality placebo versus the vitamin C group. So again, vitamin C reduces mortality. We're looking at heparin. This is a study looking at full anticoagulation in patients with COVID. All patients on a ventilator. You can see the survival significantly greater with full anticoagulation. But one shouldn't forget, heparin has a whole bunch of non-anticoagulant effects which are likely to be very useful. Most interesting, heparin actually has an effect in blocking viral entry. It acts to inhibit heparinase, which destroys this the endothelial glycocalyx, which makes the capillaries more leaky. It inhibits chemokines and cytokines, interferes with neutrophil leukocyte trafficking, as you can see, as anticoagulant, but also prevents the formation of neutrophil extracellular traps or nets from neutrophil nuclei, which act as pro-inflammatory mediators. So it's likely that in the future we're going to have specific targets that target specific proteins or pathways within the virus. You can see that up to this point, the treatment or therapeutics have really been non-specific. The question then comes about ventilation. This received a lot of attention. Doctors debate when best to put patients on ventilators. We know the mortality in New York City on a patient who went on a ventilator was 88%. So we have developed this protocol in which we try and delay putting patients on ventilators as long as possible using high-flow nasal cannula. In addition to nasal cannula, we do what's called cooperative repositioning or proning. Delayed treatment is a really bad thing, so timing is important. What happens if you delay treatment? You develop irreversible fibroproliferative phase of this awful disease. And to finish off, we're quickly going to talk about the post-COVID syndrome. So it's bad enough having COVID. The problem is people who recover from COVID, many of them don't recover. Up to 50% continue to have symptoms. Up to 50% have profoundly impaired quality of life. You can see about 50% of patients have fatigue, dyspnea, joint pain, chest pain, and this can go on for months. In addition, post-MRI studies have demonstrated because of the prothrombotic state, many patients on MRI have evidence of microthrombosis. So just to finish off, as you know, the EVMS Critical Care COVID protocol is available online. We talk about prophylaxis, mildly symptomatic patients at home, mildly symptomatic patients on the floor. We talk about the math protocol, which I've explained to you now. Obviously, one of the biggest problems has been the misinformation, lack of information, lack of understanding. Hopefully this talk will correct some of those misconceptions that folks out there have. It's really important to distill the science from the nonsense. And clearly it's remarkable the World Health Organization had to tell people that drinking bleach was not a good thing. And finally, this is from Dr. Fauci, says the chance of a coronavirus vaccine being highly effective is not great. So I think we've put too much emphasis on a vaccine. There are lots of other things that we can do. If we get a good vaccine, that will be excellent, but there are lots of things we still must do and have to do, including universal masking and improving the understanding people have of this disease. And again, most important, the truth has no sides. The scientific truth is the truth. It doesn't matter what side of whatever fence you're on. And it's really important that we do not mislead, deny, or suppress the truth. Thank you. And if there are any questions in the few minutes we have remaining, I will try and answer them.
Dr. Marik, this is Deepan. Just a quick question. I had been reading a little bit about patients developing HLH with COVID and that contributing to the pathophysiology as well in certain patients. Have you read more about this?
Yeah, so that's a good question. So that's the macrophage activation syndrome. So there's a gray area between the cytokine storm